everyone. Hi, good evening. So, I welcome you all to our second episode of Virtual Bariatric University. So, it was an honor to host all of you in the first edition of VBU. We had some great, insightful discussion with Professor Wendy Brown, Dr. Manish Khetan, and Professor Fobi in the last episode of Intraoperative Endoscopy. Over 1,000 bariatric surgeons from across the globe viewed it, posted relevant questions, and got a good deal of knowledge. Today, we are back again with yet another contentious issue, a long tube gastric bypass. A long tube gastric bypass, devised by Professor Rui Ribeiro, is also called as a diverted mini gastric bypass. With so much of controversy surrounding mini gastric bypass, a long tube bypass with diverted bile is an answer or is a breeding ground for more questions is what we want to understand. I have the tallest of leaders with me here on panel to get us through our ways and navigate through this issue of long tube gastric bypass. Dr. Rui Ribeiro will lecture on this surgery and present his seminal work. Dr. Rui, a warm welcome from India and VBU. Dr. Rui Ribeiro, the former president of the Portuguese Society of Bariatric and Metabolic Surgery. He is a proponent of diverted mini gastric bypass. He has also pioneered his work in laparoscopic gastric bypass, sleeve, biliopancreatic diversion with or without duodenal switch. He is the member of the editorial board in numerous journals. He is also the member of the scientific board of MGB OAGB Club. So I welcome Dr. Rui Ribeiro. Then we have none other than Professor VJ Lee from Taiwan. Professor VJ Lee is one of the most brilliant bariatric surgeons of the world, a surgical genius. He is the chairman of Asia Pacific Diabetes Surgery Study Group. He is also the past president of Taiwan Association for Endoscopic Surgery, Asia Pacific Metabolic and Bariatric Surgery Society, Taiwan Society for Metabolic and Bariatric Surgery, and obviously, if so, Asia Pacific chapter. I welcome Dr. VJ Lee. We are also honored to have with us Dr. Rudolf Wiener. With us, Dr. Wiener has trained generations of bariatric surgery. Dr. Wiener is the founder president of the German Society for Surgery of Obesity and Metabolic Disorders, president of the European chapter of IFSO. He is also an associate editor of Obesity Surgery and a member of editorial board of SWORD. He is an honorary member of ASMBS and other national societies. I welcome Dr. Wiener. Then we have Dr. Kamal, a prolific writer. I think he is one of the surgeons who has contributed maximum to bariatric literature. If you are published, you are accomplished. That's what defines Dr. Mahawar, a great surgeon, a teacher, and an astute clinician. Dr. Mahawar is a consultant journal and bariatric surgeon at Sunderland Royal Hospital, UK, and a visiting professor at the University of Sunderland. He is also an associate editor of Obesity Surgery, Clinical Obesity, and also on the editorial board of SWORD. He is recognized worldwide for his contribution to one anastomosis gastric bypass. I welcome Dr. Mahawar. Finally, the young talented leader from Germany, Dr. Sonja. She is a versatile bariatric surgeon. Her skills are magnetic and made her an inspiration to young surgeons in the field. She is also very well published. She is a fellow of Dr. Wiener from 2013 to 2019, and she is the head of the Obesity and Metabolic Surgery Unit in her department in Naples. So I welcome Dr. Sonja. Now we have our teacher, our clinical director of Mohak, Dr. Fobi. We also have Dr. Bhandari, the chief surgeon of Mohak, who is going to do a live long tube gastric bypass case. He has performed more than 15,000 bariatric surgical procedures. So without much ado, let me start with the Honorable Dr. Rui Ribeiro and invite him to deliver his lecture. Dr. Rui, the stage is all yours. Thank you.
Okay, thank you so much by the kind invitation. First of all, I want to thank the professor, Dr. Fobi, Dr. Bhandari, and give a My best regards to the distinguished faculty that we have here, all my friends. So I hope we can have a nice conversation. I will share my screen, if you don't mind. Are you seeing now my slides?
Yes, sir.
Is it okay?
Yes.
Okay, so the long tube gastric bypass, so-called, that we called first of all OAGB-MGB with a diversion, because it came from OAGB in order to avoid the bile reflux in a certain kind of patients. I began to do this in 2013. And it works good, so I went a little bit more for that in the next years. This is my case mix. My mainstream operation is OAGB, and in orange there is the elevated OAGB that I do a lot in pair with other operations that you can see here. Note I have no disclosures about this topic. You know that OAGB is still a polemic operation with a lot of advantages that I confirmed through the years, and I do, it's my main operation. So, but indeed, it has a very good weight loss confirmed in different studies, and in this meta-analysis from Maguliotis after 1, 2, 3, or 4 or 5 years. We can see here. Not coming. It's also very good about diabetes in a series of studies here, about hypertension, and even with dyslipidemia, the effect is better. So it's a superior obesity, anti-obesity surgery, compared with one to be better with more weight loss and diabetes remission. But with some problems like focused in this study, the higher incidence of malnutrition in a low percentage of cases, but still a problem. So certain issues are still debated nowadays a lot, like bile reflux, anemia, marginal ulcer, malnutrition, and the risk of cancer maybe. 2 days ago, there was a webinar from the MGB, OAGB club, and a lot of things have been said, like that OAGB has a low rate of bile reflux. It's true. It's not proven to be cancerogen. It's true, although it should be cancerous by now. It decreases the intra-pouch pressure, so most of reflux will improve clinically. And of course, we can also make it in a case of small hernias, but not too big. And we need to measure the bowel in all the cases in order to avoid malabsorption. Those are key points in order to have a safe operation and a successful operation. But I have also heard about that reflux after OHB happens only after technical mistakes. It doesn't seem correct because lots of excellent surgeons are doing, and they have still some cases of bile reflux. That esophagitis grade A and B is not a big problem for reflux. It can be in certain cases. It's not so important, maybe. The Lyon criteria define it like that, but in some cases may be important. And it's a good technique for after failed research techniques. When a sleeve or a band fail, we can use OHB. Okay, maybe we can use, but we don't have evidence about that by now. Only small series, and in my experience, when I began using it, I had some kinds of reflux, so I'm a little bit cautious about that, and that is one of the indications for the long pouch gastric bypass. And I heard also that we shouldn't touch any hiatal hernia when performing OHB, which is not allowed because big hernias, we know that the outcome is not going to be good. Because reflux, GERD, is the black beast of the obesity surgery, of the obesity people. It's very, very frequent. 3/4 of the patients can have reflux, more or less important in the clinical point of view. And it's controversial, but many important practitioners of the OHB reported. I won't talk about Di Maria, which is a floppy paper, but Jean Cadi, R. Groder, Mario Muzel, they found some cases of bile reflux. We shouldn't forget that, and we should try to avoid those cases that are also disagreeable. And we know that there are risks for that, a short gastric pouch, or a very large pouch, or a torsion of the anastomosis. And we know also that Roux-en-Y surgeons, when they eventually turn to OHB concept, they tend to make short pouches. Those are important factors, of course. So Mainly the early reflexes that may be due to technical points like the short pouch, retaining fundus, the large pouch, torsion or stenotic anastomosis, or the so-called afferent loop syndrome, a very important point in my view. And of course, with time, we shouldn't forget that there are also adaptive time issues. The tissues, the organs, they adapt a little bit. We know that the hiatus will dilate, but it will not dilate, but you will lose fat and it will be more floppy. And new hiatal hernias can happen in all the surgeries, not only in sleeve, but also in bypass, mainly with the tubular pouch. The pouch dilation will produce more acid, another factor for reflux. The alimentary limbs may dilate and you will make it more easy for bile to rise up to the stomach. And of course, we ask people to exercise, and we know that will increase the abdominal positive pressure, assisting a little bit reflux. So those will deal with late complaints of reflux, and we should not attribute all the reasons for reflux to technical mistakes, in my point of view. And we know that even in Roux-en-Y gastric bypass, this work from Mario Guino from 2016 showed that even with Roux-en-Y, after 5 years, three out of 4 patients have some kind of exposure to weak acid reflux, and some have also reflux and esophagitis in a very small proportion, but it is true. One of the authors that published some cases of bile reflux, Jean-Marc Chevalier, after 1,000 cases of OAGB, he said that those biliary refluxes were not treatable medically. They need surgery, and the conversion to a Roux-en-Y is a very easy and effective. I wouldn't say a conversion to Roux-en-Y because the classic Roux-en-Y, they have different pouch, different biliopancreatic thing. It's a bile diversion over OAGB. And that is an easy solution that works pretty good, pretty well, and the patients will be very comfortable and happy with the outcomes of this operation. I had also some cases in the beginning, 8 cases in the first 200. I performed that diversion, and I saw the patients very happy with the operation. So, and there is another evidence, a more recent one from Kassir, that out of almost 3,000 cases of OGB, he had only 32 cases, 0.7% of bioreflux. They converted to Roux-en-Y, and almost all the patients had a very good resolution of reflux. So it's an easy and effective operation. So it's an easy thing. We are selling in easy waters, okay? But should we get satisfied with that? No, I suppose we should do better. So that's why I began to think about using that conversion like a primary surgery. If I know that the patient will have a reflux in the future or is in a high risk of having that, why can't I prevent that and do initially the diversion to avoid bile in the pouch and in the esophagus mainly? So the initial idea for diverted OGB was to have less reflux and in a certain amount of importance, not having risk of esophageal cancer if you do believe that. But if you have bile, it's really a risk, so and we can avoid that. Not in the anastomosis. So we tried to swim to another island, and we began to perform the operation in 2013, always trying to accomplish all the technical issues of the OAGB, like the long and slim pouch, and of course adding a long biliopancreatic limb for a good weight loss. So it results in an operation with a sustained excess weight loss, a good weight loss with low morbidity and mortality, and a good anti-diabetic effect like the OAGB, and with a very low rate of reflux like the Roux-en-Y gastric bypass. In a time I call it the bridge operation because it makes a bridge between OAGB and Roux-en-Y. But of course we are always again having issues like internal hernia and marginal ulcer. We have the risk because we are going to have more acid in a long pouch over the anastomosis like Roux-en-Y. The technique was standardized in the excellent meeting promoted by the Professor Fobi and Mohak in New Delhi. It was not easily accepted, but there were not conditions at the time of the discussion because it was a very, very long discussion and it was discussed in the end. But no problem, we continued the operation, and the main technical advantages are that because of the long pouch, you don't have tension in the anastomosis, you have a better verticalization, it means less leaks. The anastomosis is wide, no high pressure in the pouch, so and no leaks, and the patient will eat better. It's less restrictive than the Roux-en-Y with a smaller anastomosis. The long biliopancreatic limb will induce a better metabolic effect, and of course, the diverted biliary induce reduced GERD incidence. The technical differences are here. We perform a pouch usually to standardize like with more than 15 centimeters. Instead of 12 millimeters, we do it with 30 millimeters, 3 centimeters. And the biliopancreatic limb is 2 meters, but we tailor it according to the patient. If it is more diabetic, we'll do it bigger, longer, and if it is young also, but it is an older people or a low BMI, we tend to decrease that measure. And the common limb, we measure the bowel all the time, even in operation, and we have the rule of having always more than 3 meters of common limb in order to avoid any kind of malabsorption in the future also. Like in OHGB, same rule. And we get different operations, one with obstipation, another one with steatorrhea, comparing with Roux-en-Y, and with a light restriction, and instead of a strong restriction, it means patients may be more happy. But the real importance is, the real difference, the important difference are the long pouch and the long biliopancreatic limb. Maybe you should call it long pouch, long biliopancreatic limb operation. What is the importance of the long pouch? If we look at that work from Capella, where they show that the long pouch techniques, like his technique, Capella or the Dr. Fobi technique, they had good outcomes. And in another paper, a more recent one, 2008, he showed that because of the Laplace law and the Posey law, a long tube is important because comparing this slim tube with that one larger tube, the flux will be 48 times bigger than this. The rule, the Posey's law says that in a thinner tube with the same pressure,
We're having technical problems.
Sorry?
We can't hear you.
No?
Yes, go ahead.
Again.
Okay. There is now, we have now some evidences of this from the group of Flick parents. They made a prospective study, a randomized control study, sorry, and they found that the extending long pouch in Roux-en-Y gastric bypass worked better with a significant improvement in the weight loss with the long pouch only. That was the only difference in that study. So why? Because for the long pouch will have less dilation with a longer restriction in the future, less adaptation, it means less dilation and a better weight regain. This is the understanding of the situation, and the difference here is clear because that large pouch will have more food than the other one. The role of the long biliopancreatic limb is evident nowadays. There are a lot of studies, and now people know that that is very, very important for the weight loss. And that work from Marinora from Portugal in 2011 using the metabolic bypass that was decided by Almino Ramos before, they showed very, very good weight loss. And now they compare with the classical Roux-en-Y, and the outcome is better. That study with Murad and Eudes Godoy also showed that for diabetes is somehow better than the classical Roux-en-Y. And that also important paper from Nergard, they showed that comparing the bypass, Roux-en-Y bypass with a smaller video pancreatic limb were longer, the outcomes were better about weight loss with longer. So there are many evidences, and that is the Elegance Redo trial, very well done by Fritz Behrens in revisional surgery after bands. They found that the long pouch, the long video pancreatic limb, they've got a better weight loss with a long instead of a short video pancreatic limb, and also better outcomes about diabetes, hypertension, and dyslipidemia, like in the meta-analysis that I showed in the beginning. So they conclude that the long video pancreatic pouch, video pancreatic limb in Roux-en-Y improves the short and long-term outcomes about weight loss, and also a good remission in type 2 diabetes, and without an increase in vitamins and mineral deficiencies in this case. This can be discussed. They tried to do the same study in primary cases. They found some difference after 1 year, but not.
Rui, we're not hearing you. We are not hearing you, Luke.
Significant increase in weight loss.
Okay.
I'm sorry, it's the internet.
There is some lag.
Sometimes it goes slow. It's okay now?
Yeah.
Okay, even Rosenthal described it in a paper in 2019, last year, a kind of a meta-analysis, systematic review showing that weight loss was superior in longer video pancreatic. So it's more or less consensual nowadays that it's important for weight loss. And this is a very important paper for me because it's retrospective, but in Italy they compared the classical the 2 meters OAGB with a tailored video pancreatic limb, and what they found was the same weight loss in that series, but less nutritional issues, less vitamin deficiencies with the tailored approach. So the tailoring the measurement will be important to avoid also the nutritional issues. And the weight loss was more or less the same. And finally, confirming that the tailoring the measures of the bowel is important, this work from Heinrich Ruiz Tovar showing us that we should have a ratio in OAGB, not in Diverted-MGB, but we can adapt of about 40% of common limb at least for having a good outcome, pointing to a BMI of 25 in the long run. And there are also some laboratory evidences like this work where they compared rats with a Roux-en-Y with 2 centimeters video pancreatic limb or 40 centimeters, 20 or 40, and they measured the blood after the glucose in the post-operative period, and look, the glucose absorption was lower with Roux-en-Y with 4 meters instead of 2 meters. 40 centimeters instead of 20 centimeters, and the glucose utilization was also bigger. And about GLP-1, being in the systemic level or in the portal level, the GLP-1 production was always bigger than in 40 centimeters video pancreatic limb than in 20. So it seems to, and of course, the weight loss here in the rats was bigger with the 40 centimeters. And importantly, and very curiously, the food intake was the same in the 2 groups of rats, but the outcomes were better with 40 centimeters. That one showed the same, infusing bile acids, labeled bile acids here in Japan, Ueno. They found a high rate of bile acids in the blood in rats with the video pancreatic limbs, comparing with the rest with the control group without any kind of operation. So the outcomes, they are published, you know that about, I evaluated 300 patients with that technique with 4 years of follow-up. It was a mix between primary and revisional cases, and the outcomes about weight loss they were fairly good, 83% of excess BMI loss for the primary cases, a little bit for the revisional as usual. But it has been a good operation for diabetes also, and control very well the case with reflux, because it's important to remember that I indicate that operations mainly in patients in risk for reflux. So, but outcomes were good, with good control, with a very few cases of reflux in clinically relevant reflux after that. You can see only 3 cases out of 300, it means 1%. And without important complications, only grade 1, 2, and 3 of Clavian classifications, some cases. And the important message is that only 1% of clinically important reflux in patients with previous risk factors. With other operations, that number, I'm convinced that it will be greater than this. And this is another short view of a prospective trial that I'm running home, because I have 3 cohorts comparing Roux-en-Y, OAGB, and Diverted-MGB, and look after 5 years of follow-up, the outcomes about weight loss is the same between Diverted-MGB, or long partial bypass, and OAGB, but better than Roux-en-Y in my patients, and again, a mixed series between primary and revisional. But Diverted-MGB has issues, and I commented before, we need to close the holes, both holes, Peterson and intermesenteric, otherwise we are again in risk for internal hernia, and I have about 2% of those cases, still some cases, but like Roux-en-Y. And the marginal ulcer, it's difficult to say, but I have just a few cases. I have now more cases with Roux-en-Y, old Roux-en-Y that I performed up to 2010 with marginal ulcers, and just a few with that operation. But I work hard about avoiding patients who smoke. If they don't want to live from tobacco, I won't operate them. I treat Helicobacter test and treat each year, and I use PPIs longer, 1 year after the operation. And I avoid to operate on smokers, alcohol consumers, or non-steroidal anti-inflammatory drugs, or other corticoids. And I'm having 2% of it also. But there are also some advantages. With more acid, at least we can improve a little bit about iron and calcium absorption, and also about B12, because we are going to have more intrinsic factor maybe. The problem of the third pitfall is malnutrition, and about this I would say that it's similar like OAGB. We need to we need to prepare the patients. We need to see which patients can hit good proteins in the perioperative evaluation. Intraoperatively, we need to run the bowel and to leave enough common channel for good absorption of proteins, and we should say to the patient, please eat well after the operation, make the lab controls, and practice physical activity in order to save the proteins and not to enter in sarcopenia clinical picture, which is very, very not agreeable. I don't know if I have time, but I have a small video just to show. We begin below this urangularis. It's not so important here like in OAGB to go further down, but because we're going to make a bilevation. But for the long pouch and the good effect, we go fairly in a place fairly below this urangularis. We pick the stomach and we stretch in order to put the magazine down as much as we can. You can see here. And the restrictive fluid, those patients they need to heat, and we want to get metabolic restriction, not a physical restriction or mechanical restriction. We go up to the east angle. Like in OAGB or in sleeve, we like to see the left pillar and try to cut 1 centimeter from that in order to avoid to cut the clasps and to damage the sling mechanism of anti-reflux. I suppose that's important. not that, don't touch the esophagus and the clasps. The mechanism. We go to the this is the measurement of the pouch. This is not a very long one, but we go for the trice and we measure the bowel. Usually we have a preconception of the length. I would say in this case 2 meters. Okay, let's ask our assistant to fix the 2 meters there, and we are going to measure the rest of the bowel. And after that, we can adapt a little bit ahead, a little bit behind, according to the patient and to the target that we want to get. This is the ileal last loop. And the anastomosis, like in OHB, we make it the same way. In this case, we went 50 centimeters ahead because there was a long biliopancreatic tube, a long common channel. And we need to count with 3 meters for the common limb and 1 meter for the alimentary limb. So what is more than that, we can use it for biliopancreatic limb safely. The anastomosis is 3 centimeters only, sometimes 4, between 3 and 4, depending if you want the patient to hit more, a little bit more or not. I will go a little bit ahead to save time. We close it manually. We make a blue test. And we are going to measure 1 meter for the alimentary limb. And this is the classical technique of the London technique or simplified gastric bypass of like Almino Ramos called it. We have learned from down both London and Almino, and this is where the way that we have done it since 2002. So this is fairly old. I mean, we do the same anastomosis and we close again with end suture, continuous suture. Then we are going to interrupt the bowel between the 2 anastomoses with a wide cartridge, 60 centimeters. We call it the Duan modulation. We try to cut close to the gastroileal anastomosis. And after that, they're going to close the intermesenteric space. And after that, the Peterson, finally. Sometimes it's not easy, it's not, it's in the end of the operation, it's boring to close that space, but we need to do that because most of the hernias in our experience were from this space. So we try hard to close it. And that's it. We use glue to reinforce the staple lines. So what we want is a lower bireflux, a low complications rate like fistulas, and a good weight loss in the long run. We indicate that operation in primary surgery, there is an important sense of and we hernias. And also for revision after failed band, failed sleeve, or bireflux in OHB. That's it. Thank you so much for the chance for being here with you, and I'm very glad that you have done it. Thank you so much.
Hello.
Hello.
Hello?
Hello.
Hello?
Yes. Can you hear me?
Okay.
Okay. Thank you, Dr. Rui Ribeiro, for your lecture. And from now, we are live from the OR, where Dr. Mohit Bhandari will be doing a live case, a long tube gastric bypass. First, Dr. Mehak Bhandari, our consultant bariatric surgeon at Mohak Bariatrics and Robotics, will be giving you a brief case history of the patient. Over to Dr. Mehak Bhandari.
So, good evening, everyone. So, I'll be just showing the patient details. So, my patient is a 47-year-old female with a BMI of 53.1
Sir, BP मेरे को
and with
बहुत
height of
चाहिए।
160 and weight of 136 kgs, non-vegetarian by diet,
ये
with
तो घर जा रही है, देखिए
comorbidities
ना।
as the OSA, osteoarthritis, and recently diagnosed but controlled type 2 diabetes mellitus. As far as investigations are concerned, the hemoglobin stands at 13.5 with protein levels at 7.56, albumin at 3.47, LDL as 138, triglyceride at 170, TSH controlled, HbA1c of 6.36, and COVID-19 RT-PCR negative. So as per the protocol here at Mohak, for the BMI of 53.1, we do a mini gastric bypass for this particular patient. But for as far as demonstration is concerned, we'll be doing a long tube gastric bypass for this patient because there would be a bile reflux gastritis. That's why we are doing, for demonstration purpose, we are getting ahead with this particular case. So now Dr. Mohit would be demonstrating the intraop endoscopy findings, and then over to Dr. Mohit.
Hi, good evening, everybody. So, as you know that in our center, we first do the intraoperative endoscopy. So I'm going inside with the scope. You can see this is the esophagus. So I'm inside the stomach, but I'll pull the scope and just visualize the Z line. So that's the Z line here for you. I think it looks pretty much okay. I don't see esophagitis or any other feature which would preclude, or any other lesion. This is the stomach and looks good. There is no gastritis. I'm here at the level of the pyrolus. It's wide open. We go into the duodenum. There is the duodenum inside. I suck a little bit of bile from there and try and negotiate it through. When I pull my scope back, I see that there is no ulcer or polyp or anything in the duodenum which would preclude us bypassing it. This is the pylorus again. I go in a retroflex way to see if I have a hiatus, which is actually not there. I have a nice hiatus there. It's not loose. And so everything looks fine here as far as the situation to perform a diverted mini gastric bypass is concerned. So I'll suck all this air while I come out. I also measured the length of the esophagus here. So while we are here, if we see the esophagus is exactly from the G junction here, 40 centimeters. So I have no problems. The length, the G junction is at the right place. There is no esophagitis. There is no gastritis. The duodenum is clear. We don't have any contraindication here to the surgery. Now I'll just take you fast through the port position. So as you can see that Professor Rui demonstrated his way of doing it. Let me focus on the port. So you can see that I have an optical port which I just put in, which is around, this patient is huge. So it's, the BMI is, around 54. So my optical port is around a palm breadth above the umbilicus. So this is the umbilicus here, but it's like above it because even though we have long scopes, this patient is huge. So we're going to go a little above the umbilicus, close to the, a little above, just close, so that the scope length is okay for us. We have 112 mm trocar, which is exactly in line with the optical trocar on the left side in the mid-clavicular line. We have 112 mm, which is another mid-clavicular line on the right side. But this trocar is placed a little bit higher, at least 2 finger breadths higher. So the reason is that this is my working port through which I'll be firing all my staples, and also I'll be doing all my surgical procedures through this particular port. So that's it. We have 2 5 mm ports, both in the mid-clavicular line, and both of them are on the right and the left side. So these are my ports. So one is for my assistant and one is for me. So this is the first 5 mm port on the right mid-clavicular line, and that's the second on the left mid-clavicular line. I'll do a quick recap of the port position. I know there are young surgeons watching it, may take a photograph. So you can see here that I have in total of, first port is the optical port, which is above the umbilicus, around a palm breadth, because this is a huge patient. Usually we would have put it a little bit down here. Another 12 mm trocar exactly in line with the optical port. This trocar, which is on the right side, where I start to work, is around 2 finger breadths above, because as I said, I need to fire my staplers. The entire thing is going to go through this port. And there are two 5 mm ports, both of them in the mid-clavicular line on the right and the left side, just in the subcostal area, and it's around a palm breadth below. So this is the subcostal area here, and I'm at least a palm breadth below both right and the left side. Now, let me switch over to the laparoscopic view. Can we have the laparoscopic view, please? Is my voice clear, Professor Fobi? Am I audible properly?
Excellent.
Yes, you're audible properly.
Okay, so now I am starting with the first step. So we're going to make the pouch first. And the way to make the pouch first is the same like Rui did just now. We just go and try and make an entry inside the lesser sac. And that's the incisura where we try and take care of these vessels. The point is that these vessels might sometimes bleed, and quite a small bit of bleeding is expected because obviously there is a conglomerate of vessels here. The best thing is some might use energy source, which is like a sealer or something. I usually prefer to use a harmonic here because I feel that that's a little faster as compared to a sealer. Since this is a super obese patient, we expect that there might be a difficult entry into the lesser sac. You can see that I have almost entered, but there are small little bit of adhesions there posteriorly. That's why we can't see the pancreas. But nevertheless, we would take care of these vessels here, which might sometimes bleed while we are firing the stapler. So I'll just seal this area so that I do not have a bleeding later on when I'm doing the procedure. So this usually would bleed if you fire the staple because there is a lot of vessels here in this particular area specifically. And when we encounter a super obese patient, we usually use a sealer to take care of these vessels. We need not use the knife of the sealer. We just need to buzz this, and once we do it, it becomes more safe for us to fire a staple. You can see exactly that we have still not entered into the lesser sac. I'm still dissecting there a little bit, so I'll just buzz here. I'm not going to rush through to fire a stapler. I'm going to see if I have a space to fire the first cartridge, but you can see the posterior wall of the stomach there. It's that area which we wanted to open, and I'm going to use a sealer to just open that area. So this is a sealer here which I'm using. If we go through the sealer, it takes a little bit more time to enter into that space, but it's more safe. So now you can see, I can see nice pancreas down there, and I have opened that space. Can I have a first cartridge? So the message here was, we can use a harmonic, but if we encounter some bleeding, vessel sealer is also a good preposition, which may be a little slow, but looks more clear as far as the blood supply is concerned. Now I come with the first cartridge. My landmark to fire my first cartridge is just below the incisura. That's the first. And I have not used the entire length of the cartridge as you have seen. I have just used almost 4.5 centimeters length just to keep the area of the passage for the remnant to basically drain properly. So we do not, if we take the entire 6 centimeters, there is a possibility that we might obstruct the remnant. Now I come with my second load, which is a blue load. At this stage, we do not usually use a gastric calibration tube. We just make this pouch. Now, once we have done with the second load, I'm now going to take my third load and call my anesthetist with a bougie. So we use here the bougie, which is of a size 36 French. And that's, I think, the only bougie size available in India. Although we also do measurements like Rui did of the length of the pouch and the breadth and so on. So now I'll ask my anesthetist to come in with the bougie. As you can see, he's bang on right there inside the pouch, and I'm happy. So now I can go and I can basically fire my third load because I'm sure that my anesthetist will enter. Now, the logic of calling the anesthetist at the third fire is that because once you have created a tunnel for him to enter, the chances of the anesthetist going into the redundant pouch becomes very less. So I have always been asked this question, that why the third load and why not the first or the second load. So I prefer to do it at the third load because that's the stage when most of the redundancy can be taken care of, because a small tunnel is made and we can direct the anesthetist through that area. Now you have this fundus there. I won't go and do a lot of dissection. Specifically, I would never use an energy source here just because I don't want to damage the fundus of the stomach. The simple trick is just make a little bit of space with the grasper and give it to your assistant. He can hold it for you and we can make an entry inside. In case we need to dissect more, I can go and always dissect. So I'll fire this load. And then when we are there at a stage of last but one, we can do a little bit more dissection here. So that's the area. I'm gonna just put my grasper there and dissect a little, not more, but that's fine. That's gonna give me an egress inside into the fundus. So you can see the grasper is already there. If there is a little bit of oozing, I can take care of that oozing with the sealer, because sometimes there are these short gastrics which can bleed. So I just give a little bit of buzz there to the short gastrics. This is obviously on the side of the remnant. And we can keep a gauze there for some time. By the time we have done the anastomosis and we are back, usually this bleeding would stop. So I'll just disconnect the pouch from the remnant. I have already made a space there. I'm gonna come inside and see. I'll pull this momentum down and I have reached that space. I'll fire this cartridge and I'm done with the pouch. The gauze could play a very important role. Small oozers which are there here, they all just stop. The blood pressure is pretty high, so we can always expect some small oozers. By the time we are back, all these oozers gonna stop. Just we put a gauze there and that's gonna take. So this is the pouch. I'm gonna measure it with my, this is my endo stitch. I love to measure with this. So you can see that that's the G junction there. I'll demonstrate. That's the G junction where my assistant is holding it. And now I can take it right with you. So with a bougie, it's around 20 centimeters. And this is the, you can say this tip lies here. So it's around 20 centimeter with a bougie straight. So that's the length of our pouch. I would say that this length is probably the one we make in a mini bypass as well. Now I'm gonna go down and just like we do in a gastric bypass, we're gonna ask the anesthetist, request him to do the patient supine. I'm gonna take, and this omentum is a little heavy, so we have to be cautious because most times this omentum bleeds while you try and displace it. So I hold it slowly and try and find some space so that I can just take care of this small bowel and search for the ligament of Treitz. So this is that area. We want patient a little more supine so that we can demonstrate table full down. Okay, now that's the area we are looking for the ligament of Treitz. So I'm gonna see if I'm gonna find it. There are two landmarks which we always would want to relate with. The first one is ligament, and the second one is in the inferior mesenteric vein. So I think I can see the ligament, and if I cannot see the inferior mesenteric vein, but I can see the ligament. So I'm gonna do some counting. Take a sealer and just buzz this. Take a sealer and just buzz this so that you don't encounter bleeding. Just buzz this. Yeah, good. Okay, so that's the area of ligament of Treitz. I'm not seeing the inferior mesenteric vein as I see it sometimes, but that's okay. I know that that's the duodenojejunal junction and I'm pretty sure about that. So that's the area. You can see again. Now I'm gonna count from here. So I have markings on my grasper. You can see this is 10 and this is 10. So I'm gonna take this here and try and measure by my grasper. So this is 10. Then I'm gonna pick it here, 20, 30, okay, a little more, 40, 50, 60, 70, Okay. 80, 90, 100. So this is 110, 120, 130, 140, maybe here 140, 150, 160. So 150 is going to be my standard BP limb, and that's this area. And around 100 centimeters will be my elementary limb to prevent the bile reflux. So in India, we can't do like Rui demonstrated, taking a common channel of 200. We need a larger common channel. But doing the reverse, counting the common channel is not required because we are going less than a 250 centimeters of a bypass. So I'm not going to count the common channel here. I'm just going to take 150 centimeters as my BP limb. So that's my BP limb here. I think that's okay. That's fine. It's going to go. So that's my BP limb. And my elementary limb is going to be 100 centimeters. So which means that this is here. So this is my elementary limb. So this is 10. This is 20. This is 30. This is 40. This is 50. This is 60, 70, 80, 90, and 100. So this is going to be my elementary limb. I'm going to just arrange the bowel so that I do not end up doing a Ru and O, or I do not get confused. So that's what was my area, which I counted around 100 centimeters to prevent the bile reflux. You know, you can always go a little less than 150 centimeters. It's what is required to prevent the bile reflux. I'm going to go a little distal to 50. It's around 100 centimeters. I'm going to make a small enterotomy here. So this is a nice little enterotomy. Okay, now I'm going to go and trace my BP limb. So that's my BP limb. And that's why we are arranging the bowel for the sake of convenience. We can also sometimes mark it, and that's fine. You can see I'm going to trace this bowel back just for the purpose of demonstration. So you can say I traced it back. We started from here. This is our elementary limb. We come, we go all the way this, and that's the common channel there. Okay, and this is the limb which is going to go up and get anastomosed, and this is the BP limb. So that's for the purpose of not doing a Ru and O. I have to demonstrate that. We always need to remember that the enterotomy before the common channel needs to go back and trace back to the elementary limb. That's what we should understand. So that's the common channel there. This is the enterotomy. If I trace it back, just help me trace it back. It comes here, 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 and it goes to this area here. It's going to be anastomosed to the pouch. So that's what is important in any gastric bypass or any Ru and Y anastomosis to avoid a Ru and O. So this is here. I'm going to do an anastomosis. Okay, 1 and 2. So that's the limb. Okay, that's fine. That's okay. Okay. It's fine. I'm going to anastomose it. And we're going to take a small, okay. Give me another cartridge so that I can close and. So that's the defect we have. And I'm going to close it with a stapler. So I just pick this area up from here. So this is the area I need to pick up so that I can close this defect, okay? And I need my assistant to pick up this area here so that we can close this defect easily. And now my trick is that I go exactly into the left subcostal area. So we pick up here. Just
હું જઉં ને એટલે અમે મારે હેર કટ કરવા જવાનું છે ને પછી આ લોકોને લેવા આવીશ સેવ કરું પહેલા ને પછી
Okay, so that's fine. I'm gonna see on both the sides. If I'm not obstructing, so I can see beautifully all the 3 limbs here and on both the sides. It's fine. I'm gonna go and fire this cartridge. Take one more cartridge. So usually I think we have gone across, but I'm not going to take any risk. Since the bowel is a little thick here, I'm going to fire one more cartridge and just get rid of it so that I'm safe. I don't like, even if I use one more cartridge here, you can see that the pins are loose. I'm going to go and just fire this one and get rid of this specimen. So that's it. Now is the stage to take an anti-obstruction stitch. So you can see a nice common channel there. That's the BP limb. This is the common channel here going down there. And that's my elementary limb. Let us trace back for the audience. So this is here. It goes back. And that's going to be the end going to be here, which we're going to anastomose. So I'm going to take a anti-obstruction stitch just for the purpose of, so this is the Brolin anti-obstruction stitch. And we usually, we would take it just for the purpose of not having an obstruction between the 2 loops. So you can see when I take this stitch, I'm sort of straightening my elementary limb in a way that the assembly goes straight. So I take this stitch at a special place, which is this. My intention is to straighten up this limb. You can see that the limb has been straightened up. That's my primary goal of doing this stitch, because I don't want the limb to, get twisted. So that's my stitch. I do this in the gastric bypass quite regularly, and this is no different than a bypass, except for the fact that we have a easier gastric bypass, like Rui says, because we have a long tube there. So not a problem. This is the stitch. You can see that by doing this stitch, I somehow prevent the kink. So suppose this get kinked like that. No, now that's not possible. I have taken a stitch and it lies beautifully. So that's my BP limb. This is my BP limb. This is my common channel. And that's my elementary limb. And you can see a good continuity. Now I have an intermesenteric defect. So this is going to go up. Now this is my intermesenteric defect. So my assistant can hold it and you can see. Now always this defect has to be closed. So what we usually would do is we would ask one of the assistant to hold it here somewhere like that for us so that we can demonstrate the defect. This is a teaching case, so I would want that all of those who are observing it will see how we do it. So now you can hold it. Good, great. So that's how we hold it. I'm going to take the elementary limb a little on the right side to expose, and now you see this big defect. Now the way we need to close it is expose it first. So the first step to close something is to expose it. So that's the big defect. Now I want to take areas so that sometimes, we create micro defects. So instead of doing good to the patient, we create micro defects. And this is a problem which is very, very common when we are dealing with super obese patients like this. So you create more defects than close one. So that's why I'll be a little close when I take these sutures, or when I use my needle. I'll be a little close, and maybe I'll be a little more cautious, because I don't want to create micro defects. So that would be my intention here. So you can see that I'm here, and I took an entire base, and the base has to be secured because the chances of creating a micro defect are more common at the base. Once you've secured this base, now you can expose the defect. So I'm coming here and I go on this side. I take small bites. I'm not going very, very deep. I'm just taking small bites so that first I make a nice closure and I don't go as deep to create some hematomas. So you can see a lot of mesenteric fat here. That's why it bleeds. I'll be a little cautious. Now, one can use all types of non-absorbable sutures here. The silk is very good. Some uses proline. Some may use even other non-absorbable sutures. We use, this is Ethibond. It is also known as a Surgidex. So this is an endo-stitch device by Medtronic. And now we can ask our assistant to leave this so that we can go and take care of the remaining part of the defect. This to me is a obese patient. And usually in these patients, I've seen surgeons prefer to do a sleeve, but let me tell you, the results here with a diverted or a long tube gastric bypass will be better because we have made a nice smart pouch there, and it's narrow. It's more narrow than our mini gastric bypass pouch, as I can say. We heard Rui talking about the Laplace's law. So it's a little narrower than what our mini gastric pouch would be. I think mini gastric bypass and gastric bypass are two very, very different procedures because they are based on two different concepts, whereas mini bypass is very malabsorptive. This is more, gastric bypass is more restrictive. A diverted bypass is a little combination of the two. So now we have reached a stage where we are almost through with our intermesenteric defect. I'm happy with this closure. I'm just going to take a single stitch more and then going to take the knot before I start to do my anastomosis. So that's done. We again check, cut. So we again check for what we did. That's the elementary limb. That's the common channel there. And here is the BP limb. So that's the BP limb going up here. That's the common channel, and that's the elementary limb. And if we trace it back completely, we are going to come here. So this is done. Now I'm going to make a small enterotomy here, and we're going to do some dissection at the pouch. But even before we make the enterotomy, let's see how the gastric pouch looks like. So this is a little narrow. So I'm going to use this entire area to anastomose. Usually I remove this fat. So I have I feel bad when we fire the load and this bleeds. And this would in fact bleed much more when the blood pressure is high, and that's what we face. So I just sort of remove this fat usually when I operate, and then we make a gastrotomy over the tube. So our anesthetist is pushing through the tube, and we make a gastrotomy. You can see the blue of the tube. It's a small one. This is the elementary limb. I'm going to make an anastomosis of around 4.5 here, around 4 to 4.5 centimeters, which eventually would be, like same. So although the length of the bowel distally is, say, around 2.5 centimeters, so it does not matter. It converts into the same. But we just make a little wider anastomosis here because that's the principle we follow. A little wider than our gastric bypass. Gastric bypass would be around 2.5. This would be around 4.5. So a little larger and wider anastomosis. That's our bougie there. I would remove it. We're going to go up, and I see this. Now I'm going to come here with my other limb. Now at most times, we would see that this is fine. That's okay. I'm going to fire this. You can see it's 4.5. It's not exactly 6. It's 4.5, around 5 centimeters. So that's the anastomosis. Now I'm going to close this anastomosis before I close the Peterson space. This is similar like Rui demonstrated in his video, although we secure both the corners, the corner above and the corner below. That is the caudal and the capillate corner, just because we feel that leaks happen at these sites. I do a little bit of suturing here, 1 or 2 knots inside the anastomosis. That's a little different technique. Usually surgeons would not go inside the anastomosis, but I do. And I take just a little bit of bite from there, and then we come outside like in a Connell's, like the way we do in a Connell suture. So that's fine. I'm going to come I'm going to come inside now. So that's the corner, and I'm concerned about this corner because that's what we need to, very cautiously sort of control. So you can see I am demonstrating you this corner, and that's the important step in the anastomosis. So that's fine. So now, once we have taken one conal suture, I can demonstrate you both the corners. So you can see this is one end, this is the other. I'm going to take a bite from here. I'm going to pull this. And again, I'll expose before taking or doing anything. This is the area I need to take a suture from. The best way to do this is to expose first, then to do anything else. And then I pick this up.
One more.
Okay, so that's my caudal corner. I'm going to cut this suture here. Take another gauze. So we'll take another gauze. So you can see that this corner is secured. And I would not continue suturing here. This is the corner, and you can see that this is completely secured. I'm going to demonstrate that to you, everybody. That's fine. I'm going to cut my suture here, maybe one more bite, and then I can cut that. So I'm very sure that this particular corner is secured. So that's fine. Okay. Okay. Also, if you can observe in the PIP image, I'm using a very long suture. The suture comes from my port. If the cameraman can demonstrate, the suture is out from my port. So I'm using a suture which usually laparoscopic surgeons would not use. This is pretty long, around size 40 centimeters. So I'm not wasting my suture. And that's the benefit you can have with using an endostitch device, that you don't waste sutures. You can take a little longer suture and you can manage with it because it can come out of the port, and this device can help you use the same suture for the one anastomosis. You don't require to have two sutures for doing a cephaloid and a caudal end separately. So that's what I did. Now I'm at the cephaloid end. I know that I'm beyond my anastomosis. So I'm here. Now this helps me to do a little bit of triangulation. I can come and I can just go on suturing. I utilize the staple line to cover the anastomosis. This also helps me in a little bit of hemostasis, because you know that I use a gold, which is a little, sometimes bleeds, because that's a little bit more on the height size as far as the staple is concerned. But that's a tricky thing, because if you use a blue here, I have seen the cartridges getting loose. So I usually would use a gold here, and that's the reason why we are very secured about this area, because the area close to the antrum here on the lesser curvature side is sometimes a little more thicker than we think. So that's the reason why I use the gold. And we incorporate this into our staple line, and also I do a posterior anastomosis opposed to Rui, who did an interior. It doesn't make any difference as far as I'm concerned. I don't want to leave the staple line posteriorly, so I just take it anteriorly, because most of the time that staple line posteriorly is, I'm little afraid at that, and that's why I sort of incorporate that. Now we reached the part, the caudal area, where we just took a stay and stopped and cut the suture. And I'm gonna get back to that area and gonna tie this knot. So that's it. I'll do 2 or 3 throws, because sometimes this vicryl can get loose. So that's fine. I have a nice anastomosis. I'll ask my assistant Abhishek to measure it before we close the Petersons, and then I can do an endoscopy and demonstrate you the internal anatomy. So we are done with the case. Let me measure the length of this anastomosis. I'll use this device here. So let me see. I think it should be okay. So that's so if we start from here, that's the length here maybe. So it looks around 4.5. What we measured in our cartridge is the same. Can we have the patient a little bit supine? Now I can close the Peterson space here. So you can see that there is a Peterson space. And this is an anatomy in a Roux-en-Y reconstruction where this space is more pronounced. So can we have patient more supine? Give me another grasper before I demonstrate the. So the first step is to demonstrate this space, because if you want to close it, you need to demonstrate it. And in super obese patients, it's usually a little difficult because you have a lot of fat which is dangling around, and that's what is happening here. But I think I have a good space here to demonstrate. So that's my Peterson space, and this is a space where you can expect the bowel to come. But the first step I would do is hold that space properly, demonstrate. So you can see now. Now this is the bowel which I suspect can get inside. So that's the bowel, and I'm not gonna pull it inside, but I'm gonna close this defect for you. So again, as we did in the intermesenteric space, we don't want to create a micro defect for us. We want to do good so that this has a longer lifetime surgery. And maybe if we expose it better, like we do by the first trick is to make the patient more supine, maybe a little more so that all this momentum can go back towards the transverse colon, and we don't have at the same time, we can just go on taking sutures from the area, and that's what will benefit us at this stage. So you can see that my base has to be covered pretty well, because that's the area which can cause more problems than doing any benefit if I close this. I have seen mini gastric bypass surgeons not closing it, and we also are not closing it doing a mini gastric bypass, but in a Roux-en-Y anatomy, I feel more secure to close it. Also, I think that's one area of demonstration where I think young surgeons learning the anatomy may understand that this is a potential defect, and as I demonstrated, it creates problems if we don't close it. Now I can come here, go closer to what I took previously, and then I can go there. Okay, so that's a little. So endo stitch is actually making my job a little easier because it's not an anatomy which is very conducive to, closure of such defects. Now I see this. This is good. So I'm just gonna take a little, not too much, not too less. So what we are principally trying to do here is create some good adhesions, and that's going to help. So you can see that I closed it. I can take one interrupted down if I feel that that area needs a stitch or so, but I'll go and demonstrate it. If we feel that we need one more, we're going to take a single stitch there just at the base, because there was a lot of pressure at that area. I don't feel so, but let's go and see. Okay, let's cut this and let's go down and see if we need to take another stitch, little one, just single interrupted one, just to close the defect. So that was a huge defect to close, and as you can see, I'm already done. I'm just gonna see if I need to take another stitch or so. Maybe just a cover, a little cover there. So this is one. Okay. And another one just close to it. Okay, that's fine. Yeah. So that takes care of the mesenteric Peterson space. And we have been meticulous as possible. I'm going to come in with an endoscope now. So just before I come in with an endoscope, let me do a quick recap of the anatomy we created. This is a diverted mini gastric bypass. Sorry, forgive me, a long pouch gastric bypass. So we started first from here. We made this pouch. I'm going to do a little bit of hemostasis once after I do an endoscopy. Just maybe 1 or 2 clips here. Give me a clip. Most of it usually would stop. This is just one where we need to do a little bit of hemostasis because the blood pressure is a little higher. But that's okay. That's fine. Most times this bleeding would automatically stop, and we usually would use the clips at our center to do the hemostasis. So that's what we use. I think that's fine. We can go ahead and do some more hemostasis. So I'll demonstrate you the anatomy. This was my pouch. That's my anastomosis. This is the Roux assembly. That's the BP limb. That's the common channel. This is the intermesenteric space, which we closed here. And then we did the anastomosis here. And then we came in and we did a Peterson space closure. So I'm going to go up towards the endoscopic side to have all of you see the endoscopic view. In the meantime, my assistant's going to block the elementary limb so that the gas does not pass that area. Can I have the PIP main screen there? Okay, nice. So I'm into the esophagus. My anesthetist has kindly bent the neck to help me have access inside the esophagus, which is tough. So you can see the Z line, nicely seen Z line. Now I'm going to come inside. This is a nice pouch. This is the staple line. We go inside. That's the anastomosis. So that's the anastomosis there. And I'm going to go, let's try and go beyond it. So there's a little bit of turn here. So that's my, okay. So I'm inside. You can see, all of you can see that I'm already inside into the loop nicely. I'm pulling the scope back very slowly. This is the anastomosis. All of you can see the anastomosis here. I pull the scope, pull the scope back. Nice looking staple line. I just keep the staple line in view of all the surgeons there. I'm going to pull the scope back. You can see nice staple line. It's not bleeding inside. You can see it's not bleeding inside. It's not bleeding inside. It's nice looking, nice looking. I'm going to do a little bit of suction so that I come out. So that's it. You can focus here on me. If there are any questions, Professor Fobi, Dr. Kamal, any questions?
Let's let the assistant put in the scope, so we'll make a few points.
Okay, okay. So the scope is inside, yes, and I'm ready here.
The first thing which Dr. Bhandari didn't stress was for you to notice that the stomach nor the small bowel was dilated. The most common question everybody asks, based on thought, not demonstration, is that doing an endoscopy intraoperatively just because of the fact that insufflating the patient would cause dilated loop of bowel and make your surgery difficult. As you could see there, the small bowel was not dilated. And the reason Dr. Bhandari can explain to you is we use CO2 and we do minimal insufflation. The second thing is you can demonstrate how far you're away from the pylorus. So they can realize that.
Yeah, I'll demonstrate. I'll demonstrate that. Let me go and let me see. Okay, so that's the assembly. I'm going to show you the area of the pylorus. So let's go in here. So my staple line starts from here.
What
Can you see
about
that?
test?
Can you see that?
Yeah.
And that's the pylorus is here.
Okay.
Okay, so it's around 2.5 centimeters from the pylorus.
Okay. Then the other thing is when you went in, I know you just do it instinctively. By the algorithm we use, what are the most common contraindications for doing the MGB or the dilated MGB is the status of the liver. So we went in and found this liver was a little bit more cirrhotic. It's mainly fatty liver right now. That would preclude doing a malabsorptive procedure, and will therefore either do a gastric bypass or just a sleeve gastrectomy. Any of the panelists have any questions? We'll start here now and go over. Dr. Chipata, you sent us a slide presentation, right?
Yes, I did. But maybe can I comment, Rui? Congratulations, Rui, and obviously congratulations to surgery. Great work. I want to comment dumping syndrome, because Rui, you said, or I have read in your work that you didn't have any case of dumping syndrome after diverted MGB. So can you say something related to dumping syndrome?
Sure. What I found is a very low rate of patients with some symptoms of hypoglycemia. I suppose you are commenting about hypoglycemia, late damping. But they are not important. I've never had a patient with fainting because of that. Sometimes they complain a little bit, but it's easy and much lighter than in Roux-en-Y, that I had very serious cases before, and even now I have some, but the rate is certainly low. About the early damping, I suppose it's more or less the same like Roux-en-Y. Some patients complain, but you can manage it easily. But no serious cases, no important cases.
Okay, thank you.
Go ahead, Dr. Wiener.
Yeah. Hello, congratulations, very nice surgery both. For the beginners, maybe it's easier to avoid mistakes, maybe in the limb, to make a wrong limb. If you have this procedure done like Rui is done, and only if you are very experienced, you can make this free-handed Roux-en-Y at first before you do it. You know, it was a little bit for experienced hand, it's clear, which is the bilipancreatic limb, like Mohak has done. And no, I lost the picture. You can hear me?
Yeah, we can hear you. Yeah, Rui, we can hear. Dr. Professor Wiener, we can hear you. Go ahead.
And both was absolutely safe and clear, but for a beginner, it's easier to bring up the limb after measuring the bilipancreatic limb and then dividing the limb and make the enteroanastomosis. Just a recommendation for beginners: if you do the first surgery, you can. It's very difficult, especially in such obese patient, to avoid to take the wrong limb. Maybe I remember we had also live surgeries in Frankfurt meeting, and Michel Garnier has done doing a switch, and there was an extremely obese patient, and he mixed the limbs. So maybe just a recommendation for beginners. And if you have done some cases, then you can do it a very professional, like Mohak has done this at first. And you know, it's sometimes very difficult to understand if you're starting which is the right limb and not to make a mistake. Just a recommendation from my point of view. I have some slides. Main concern, what you have to learn from this, if you look in a book and just reading an article, and then you will start this procedure, you will make a mistake. The most important thing is here to calibrate the long pouch, and not to make a free-handed like the MGB, like Rutgers has done, the wide free-handed gastric pouch. Then you have a lot of ulcerations. Because it's a high rate of acid production, and you need a longer PPI medication, maybe lifelong. This is on the background.
Yeah, and if I may, more than that, I suppose that about the GJ, the internal anastomosis, it's very important what Mohit said. I would like to stress that we need to take care about the outlet of the elementary limb, because if we, even with the end suture, if we make it narrow, the people will have complaints of low output of the stomach, and they will vomit and have a lot of nausea. So be sure that you are having a elementary limb outlet large enough in order to avoid any kind of stenosis. And that's right, we need a very, very slim pouch and with just a few acids.
Dr. Mohawa, do you have any questions for Rui or Mohit?
No, not really, Professor Fobi. It's a great talk by Rui and great demonstration of procedure by Mohit. From my point of view, you know, it was almost like what I do with Roux-en-Y gastric bypass. It was a longer pouch and a longer BP limb. Everything else seemed similar to what I do with the Roux-en-Y gastric bypass. So no, thank you. Great talk, great presentation of surgery. Congratulations, Mohit.
Okay, Wejili, you have any comments or questions to either of our presenters?
I had some slide.
Professor Lee, can you be a bit louder?
Can you share my slide? I have sent a slide to the coordinator.
Okay, we'll put up your slide. Vinny, just put up the slide for Professor Lee so that he can make his point. We are just putting up your slide. In the meantime, I just wanted to respond to Professor Wiener till we have Professor Lee's slide put up there. I absolutely agree. I think for the beginners, they can do the loop technique and then they can divide the loop. So they are sure that they don't make a Roux-en-O. And also, we can always trace back the common channel, which should come to the elementary limb. And then once we are confused, I always say that we need to keep this assembly in a C-shaped pattern where you have the elementary limb on the right and the BP limb on the left, and the common channel clearly seen. A second advice can be that we can mark these limbs by two different colors. Maybe we mark one of the limbs with a vicryl and the other with a silk so that we are not confused. To do the loop technique is always easier, as Professor Wiener correctly said, because we know that bringing a loop up to get anastomosis also gives us the freedom of deciding if the loop is coming up easily. So we can easily go more on the side of the common channel or more on the side of the BP limb, depending upon whether the loop is coming up easily or not. The case is not so bad here because this is a very long tube, but if we do a gastric bypass and we do a loop gastroenterostomy, it's always much easier. And once you progress to these number of cases, then you can probably shift to these technique. So great points. Also, I agree with Professor Wiener that we need to make a very, very small pouch, small as in a narrow pouch, not small, a narrow pouch here so that we can avoid as much as parietal cell mass as possible. And we need not be as liberal as we are in mini gastric bypass pouch to avoid a lot of marginal ulcers. So both are very, very great points made by Professor Wiener. Do we have slides of Professor Lee ready? Okay, Dr. Lee, your slides are ready. Can you start?
Okay, I would like to congratulate this workshop and nice operation and nice presentation. My comment is we had to this long pouch revision report in 2011. At that time, we report two kinds of procedure. One is the long convert to Roux-en-Y, another is convert to sleeve gastrectomy. We'll provide some data there. Can I go to the next slide? Yes, so my first comment is, can we use this revision surgery for weight regain after OAGB? Yes, but may not be adequate because if you look at the data, when you convert to this, you probably increase some BMI decrease about 3, but you increase some malabsorption, of course. So for most of the weight regain after OAGB, you need to consider gastric tube restriction in additional. And also, if patient have reflux symptom, I think it's not appropriate to just convert to Roux-en-Y. And of course, everybody knows we need to measure the bowel length. And the next slide. And if the patient with frank bile reflux, sometimes it's not only the anastomosis or torsion of the bowel. So usually we need to consider to revision the GJ anastomosis at the same time, not just convert to Roux-en-Y. And usually it's patient also with some part of the weight gain. So you have better to redo the GJ anastomosis and move distally. And in many patients, especially smoker, we need to think about combined thrombovagotomy. So it's many things more than just convert to Roux-en-Y, than just simply Roux-en-Y thing. So most of the time I will do distal Roux-en-Y GB for this kind of revision. Then the next slide. The third comment is this procedure usually is recommended for revision surgery. We published 2005 for the VBG at the beginning. We find it's a good operation to do it, treat the tube and do a bypass. Then the next slide. But for sleeve, you need to look at the gastric tube. In this case, gastric tube is good, as is good a candidate for the OAGB revision. But for this kind of approach, of course, everybody do Roux-en-Y anastomosis. So it's a good option for patients without GERD after sleep, but not many. So Roux-en-Y is still the best considered for this kind of sleep tube. The next slide. Then revision for adjustable band. I think in the paper of Louis, he had mentioned revision surgery for this kind of restrictive have a higher instance of GERD. The problem is this kind of restriction band probably end up this kind of stricture as here. So patient will have some symptom even after you convert to the OAGB. However, if you want to change this situation, you probably need to do a very high level Roux-en-Y gastric bypass. And it's pretty risky in this kind of patient. So in this kind of patient with weight regain after band, we still prefer to do a mini gastric bypass. Why? Next slide. Because we had published last year in restrictive type, while osmosis provide a better weight loss still than Roux-en-Y gastric bypass. You can see the exact weight loss is better in OAGB. However, the advantage is the operation time. You can see if you do a Roux-en-Y reconstruction, you spend a lot of time in doing the Roux-en-Y as we see the demonstration. You need to close the mesentery, a lot of things you need to do. Okay, the next slide. Can we share the next slide? Okay, this is the last comment. So how about do this long tube as a primary surgery? So we need to look at the paper and think what is really benefited for you do a Roux-en-Y reconstruction. I find the advantage is only decrease the probably bile reflux from 2.5% to 1%. That means you do 98% of the patient unnecessary to do a Roux-en-Y reconstruction. What is the disadvantage of a Roux-en-Y reconstruction? In our long-term follow-up, we can see Roux-en-Y reconstruction will create a long-term about ileus, about 4%, in contrast to the 1% of OAGB. Also, the paper in Louis also showing increased marginal ulcer when you extend the long. 14% increase of the risk if you use one more step. So comparing the benefit and disadvantage, I still want to do the OAGB on primary surgery. There's really no convince of data to convince me to doing this long tube Roux-en-Y reconstruction as a primary surgery. So conclusion, the last slide. So my comment is this is a good operation and can add to our armature, but maybe indicated occasionally in very few cases. So that is my comment. Thank you.
Thank you very much. Thank you very much. Sonja, do you have any other comments?
Yeah, I have a slide on my desktop. Maybe I can show it.
Please.
Can you see it?
Not yet. Himanshu, share the screen and everything, please.
Now you can share.
Okay, I'm sharing. Okay, here it is. Because the question is the diverted MGB a good primary option? And these are our data from Germany from some years ago, because we started to have experience with diverted MGB as not a primary procedure, but due to difficulties. And the first thing is when you do an OAGB, MGB, and you have difficulty, surgical problems with the anastomosis. We had a small 2x small intestine perforation. So we divert it automatically to resolve the problem. And the second thing is in patients with biliary reflux after OAGB, obviously we diverted and we had good results. And this is our experience from, I have to say, secondary diverted MGB. So now the question is, as Lee said, now when do we have to prefer the primary diverted MGB? And I think the two pitfalls are really important. The internal hernia is important because we have seen in long biliopancreatic limb wound Y gastric bypass that there were more internal hernias. Mohit, you did a great closure of the defects, but it's really important, because if we had 2% of internal hernias with closure, you know, you have 8-9% without closure. So I think this is really important. And an important thing also, I think Lee said, is abdominal pain. You know, we have a lot of studies who show that Roux-en-Y gastric bypass patients have abdominal pain without any relation. Yeah, you have to exclude an internal hernia, but they have more abdominal pain than MGB patients. So we have to think about this problem also, quality of life. And so I think I'm convinced that long pouch, long limb Roux-en-Y gastric bypass is absolutely better than the standard Roux-en-Y gastric bypass, because you don't have the dumping problem. You have a better weight loss due to longer biliopancreatic limb. But Rui, in your opinion, isn't it better to perform primary MGB? I am more fast. I can do 1 surgery more a day. So I can do 5 instead of 4. And in the case of biliary reflux, I can convert after, I don't know, 1, 2, 3 years. So what is your argument?
Sure, but look, that's what I'm doing. I show you. I would say that I would perform 1 diverted for each 3 or 4 OAGBs, regular one. I do agree with what Dr. Wei-Jie. It's better to do a OAGB because the outcomes are better. Maybe we don't have the issues, so many issues of internal hernia. There are some, and of course, even the marginal also will not be so different. But for a regional surgery, I don't agree with him, because I have done a lot of OAGBs after failed sleeve, for instance, and most of them, they have both problems, bile reflux and weight regain. And you know that if you with weight regain, biliopancreatic limb, a long biliopancreatic limb is the issue. And if you have the reflux, is the Roux-en-Y gastric bypass. And that operation, the diverted OAGB, combines both advantages. Of course, we lose something like the concept, internal hernias, the marginal ulcer, but we can deal good with that. And the internal hernia may be the more important problem. I do agree also with what he said. It's the chronic abdominal pain after any kind of Roux-en-Y gastric bypass may be possible, and it's also disturbing for the quality of life of the patient. But we don't have a good solution for that. It's like that in Roux-en-Y and in this operation also, which is in the end a kind of Roux-en-Y. Maybe that's connected with the way that we do it lateral. Maybe with the terminal lateral anastomosis, the problem will be less, and we can deal better with the chronic pain, abdominal pain. Let me say something also about the bowel habits, because with that operation, the diverted, comparing with the regular OHB, we have less steatorrhea. I don't know why, but maybe because of the influence of the alimentary limb, those patients don't have so many bowel movements a day, and they have steatorrhea the same way, but not so important. And that's a defense, I suppose, for malnutrition. And malnutrition is probably the more dangerous complications of OHB nowadays.
But here, I may have also 3 pictures.
Okay, Dr. Wiener, please.
Maybe Winnie can upload these 3.
Yeah, Professor Wiener, we are uploading it. Please upload Professor Wiener's.
Yeah, you know, just another topic. In the long term, we have 2 main problems. From the point of view of the patient, it's the weight regain, the most important. From our point of view, is malnutrition in the long-term run. The weight regain will happen after all procedures if they are not banded. So, I'd like to see another one. We talked about the PPI and the ulceration problem after MGB and diverted. There are 2 other pictures. And what is the background for weight regain? The volume of food uptake is increasing. So if it's not banded. Yeah? So what we have done in the past with the Roux-en-Y, make a micro pouch, this was the wrong way, because make it smaller, we have more dilatation of the alimentary limb. And we can have also a dilatation of the common channel. If you have such a free-handed, what we're seeing here, this was a free-handed MGB. And sometimes it's too large, it gives no resistance. So the next picture, please. Winnie, the next picture, please.
Yeah, we are coming up with the next picture.
And you can have this,
advance the slides.
That now?
Yes.
another one. And if you have not this so small long tube, calibrated long tube, then you can have also a dilatation of the common channel and also of the pancreatic limb. I'd like to show you this picture. It's the same problem what we had with the unbanded Roux-en-Y gastric bypass. The same what we have with the sleeve. If the antrum is dilated and you have a increasing antrum reservoir. Winnie, you can find this picture. This is blue and red colored.
Himanshu, advance the slides, please.
There's another picture. This shows CT volumetry of a MGB, which is not done properly. Too small, too wide gastric pouch, and you see the same dilatation of the alimentary limb, like we have seen after 2-3 years in the long-term run with Roux-en-Y. I'm sorry that she cannot find the picture.
Mohit, can you go to Himanshu and make sure he knows we're having a problem?
No,
please.
Sir. Trying to find out a picture of Professor Wiener, so which he wants to share.
Okay, all right.
I'm here with Himanshu only.
Thank you.
Right inside the studio. Just close this.
And it gives a more resistance, more restriction if this on the lesser curvature, this calibrated narrow tube. This is important. If you have not a bending, there's another topic to make it bended or not bended, but this gives more restriction and more long-term preventing the dilatation of the small intestine. Yeah, you see these pictures. So on the left side, you see a Roux-en-Y gastric pouch, a bypass with a short pouch and a dilatation of the aluminium and the candy cane. And this patient regained weight, was not bent, there was no Fobi ring. So this is typical picture after 5, 6, 7 years after Roux-en-Y gastric bypass. And on the right side, this MGB was not done properly. The pouch was too short and the diameter was too wide. And you see it's an extreme dilatation of the common channel on the left side and the bilipancreatic limb on the right side, because there's no alimentary limb in the MGB. So you can see, and this is a mistake. It's a surgical mistake, and the patient started to regaining weight also after MGB. If the patient is able to eat too much, the malabsorption should be, then you have to extend the bilipancreatic limb, just to demonstrate that the long term run to be preventing weight regain, also in such cases, if you have only just a bilipancreatic limb of 150 to 2 meters, you have to make this narrow gastric tube that we have seen in both procedures, Rui and Mohit, very properly done. Thank you very much.
Thank you very much. Kamal, are you really concerned about what would be your opinion about marginal ulcers with this diverted one anastomosis gastric bypass as a primary procedure?
So, I mean, if you just focus on the ulcer side, Mal, we know from the Roux-en-Y gastric bypass data that ulcer incidence is not just dependent on the pouch size or the parietal cell mass. And we saw from the Boerboom and Brent's randomized controlled trial comparing 5 centimeter long versus 10 centimeter long pouch that we also presented about, that there was no difference in ulcer rates between the two groups. My personal bias, and I think I've said it in multiple forums, is that the ulcer rate is inversely related to the duration of PPI prophylaxis. Because what we forget is that a large number of our ulcers are related to the foreign body that we place, which is the clips. So in my view is that while the foreign body is being covered by the mucosa, which can take 2-3 years, it would be adequate. It would be better to protect patients with PPI prophylaxis to reduce the ulcer rate. And obviously other factors are very well known. Smoking, some studies have also found diabetes and hypertension as risk factors. So I think that is there. But with regards to this particular operation and the longer pouch leading to more ulcers, I don't think that will be the case.
Beautiful. Well, at this point, let's go back. Mohit, do you have any particular comments you want to make?
I just wanted to ask that, and in fact, I wanted to ask all of our panelists. I know Dr. Fobi works with me, so we do not usually do a long pouch gastric bypass until unless we need to do it as a revision procedure. But my question would be to Sonja, to Professor Lee, Kamal, and Professor Wiener. Where do they see this procedure fit into their practice? Where do they see, what is that sort of a case where Professor Wiener or Sonja or Professor Lee or Kamal would do this procedure? I know that Rui would do it because he is sort of an innovator, but I want a very balanced perspective as to what are those situations when all 4 of you would do this procedure in your practice. So we can start from Kamal and then, you know.
So I would not do it for primary procedure because as many others have said before me, it takes away all the advantages of OAGB in my practice. I make a long narrow pouch and I do a standard 150 centimeter BP limb for all OAGBs. But I would use it as a revisional option for patients who are developing persistent reflux after OAGB. And for them, we do exactly the same thing. We leave the pouch and the initial GJ untouched. What we do is a 50 centimeter Roux limb. We don't do 100 centimeters. And I do second anastomosis and then divide the bridge between the two. So in my practice, it would only be for the treatment of patients with persistent reflux unresponsive to medical management after OAGB. It would not be a primary procedure in my practice.
Sonia, what do you think?
I have to say, I also in this moment prefer MGB. For me, the only contraindication for MGB is a large hiatal hernia or esophagitis, C and D. In this cases, I perform room-wide gastric bypass, standard gastric bypass, with a long biliopancreatic limb. But I have to say, after the discussion today, the argument of Rui, who said after failed restrictive procedures, sleeve and gastric bending, I think it's a good option because a standard room-wide gastric bypass does not have further weight loss. In my opinion, I'm revising a lot of bands, and MGB, we know that revisional procedures have more bireflux. So I think it's a great option after restrictive procedures to perform the Diverted-MGB to avoid further complications.
Thank you. Go ahead.
Wiener and Professor Lee.
Virgily?
Professor Lee?
I think we can see in the past 20 years, the gastric bypass, room-wide OAGB, they coming together closely because we now knowing more. So now we use longer gastric tube. So even in room-wide, they recommend use a longer sleeve tube to increase the efficacy. And OAGB, just like sleeve, use a long tube. I think it's the most important thing for both procedures. Then for reconstruction, you can see, and necessary, we will do OAGB wire osmosis unless you have a good indication, good reason to do a room-wide reconstruction, because room-wide reconstruction costs some price, internal herniation and abdominal pain. So I think now we gradually going to. And about the BP limb, I think both procedures now elongation the BP limb because you want increase metabolic effect. And at the same time, you need to know the common channel. In Western, I think 3 meters is enough. But for Asian, we measure the protein intake is really lower in Asian population. So we keep common channel 4 meters. So I think now the consensus is going to the basic is construction for a mini gastric bypass or room-wide gastric bypass. You can choose as your preference. But for this long tube gastric room-wide, I still thinking what kind of patient I need to do. But unfortunately, not yet to think about.
That's being very honest and candid. That's what this forum is about. Rudolph, what do you say? I know you're not operating much now. Are you still operating, or Sylvia has taken over the whole practice?
No, I'm this week full in OR.
Okay.
85% I'm doing MGB. There's only one indication for room-wide. First, it's Barrett or Seaver flux disease, dirt, and second, American insurance. In this case, we have done the bypass, the room-wide, since years with a long gastric narrow tube done. And now what we have done also, we have a longer 100 centimeter biliopancreatic limb so far. Maybe it's a little bit more like Rui, but we're not going into the antrum. You know? We're going just on the incisura horizontal. And this is a room-wide gastric bypass, what we have done since years. We have never done the micro pouch, never, as it's 20 years ago maybe.
Fantastic.
Kamal, this is what you said is my opinion.
Professor
Thank
Fobi,
you.
We have some questions from the audience for Rui, for Kamal, for Professor Wiener, for Suri. Can I ask those questions if you permit, or you want to go ahead and?
We have 5 more minutes.
Okay, so I can ask those questions. So the first question to Professor Rui is that Professor Kesava Manur from London, I think he's in India or London, I don't know, but Professor Manur is asking a question that he finds that he has a lot of nausea after long pouch RYGB compared to the short one. Rui, do you have an answer to him?
Yes, I have an answer. I have answered him in private in the chat, but I can't find those cases. The patients with diverted OHB, they behave normally as OHB without nausea or difficult process. But I take a lot of care, as we have shown in your excellent operation, trying to get a right axis between the pouch and the alimentary limb. They should be immediately in a straight line. If you do that way, and if you have enough large anastomosis, there is no reason for nausea unless there is a problem with enteral anastomosis. As I said, we need to be careful how to do that, because if there is any kind of torsion, for instance, if you are closing the intermesenteric space and you approach too much the bowel and make a kinking and you don't notice, you are going to have nausea, or maybe because of the dilation of the pancreatic limb or directly from the alimentary limb. So we need to be cautious about that, like in OHB, to get a straight line between the pouch and the alimentary limb. That's very important.
Okay, Dr. Sanjay Patolia from Ahmedabad and Rajkot, he would want to express that he would never use this procedure as a primary procedure, but would do it just as a revision for maybe bile reflux, because he feels that your procedure is too much for our Asian set of patients. We, as Professor Lee also mentioned, in Asia, we cannot keep a common channel less than 250 centimeters. We need a 400. So he is a bit skeptic about the length of the BP limb. I have one last question, because Professor Fobi said we need to close. Rui, can we use this procedure as a metabolic procedure in low BMI diabetics? What's your opinion? I have had Professor Lee, who published a lot upon mini gastric bypass, limb, moderation of limb lengths and different limb lengths for different BMIs. And I think Dr. Lee has published it in a big way. But what's your take on this being used on BMI like 25 or 28 BMIs, and specifically in Asia, because we suffer from a lot of diabetes? What's your take on that?
I would say that I could use it, not too frequently, but why? I'm doing for people in grade 1 obesity, I'm doing OHB in 1 meter, 120, sometimes with about 35 or 34, 150 of biliopancreatic limb. So, and it works good. But if one of those patients has a grade C or D esophagitis, I won't want to put him in risk of bile reflux. So I would go for that operation, but I need to have the care of measuring all the bowel. And my rule is, if you have 3 meters, maybe it's too much, but with 3 meters, you don't have risk of any kind of malnutrition or hypoproteinemia or anemia, whatever. So you can control, and if you can get 120 and 1 meter, 120 of biliopancreatic, 1 meter of alimentary, if you have 3 meters down, you are in a safe ground. So don't be worried. I could use it, but it's not usual. Usually those patients don't have big problems about reflux. That's the main indication for this operation, I would say. Another last issue, mainly for super obese, sometimes like OHB, you know that OHB is a wonderful solution in order to have a lower anastomosis with less tension. Sometimes the mesos, the thick mesos, don't go upwards a lot. It's very difficult to make the anastomosis high in one eye. In this kind of operations, if you have chosen to do a Roux-en-Y configuration, you can use this configuration, and your anastomosis will be low enough at the level of pylorus or below without any tension. That's another situation when this configuration can be useful. But I would repeat, it's not my main operation. I use in selected cases when I think it's important to protect the patient from bile reflux mainly.
Okay. I think I have a lot of questions, but I think Professor Fobi wants to answer some closing remarks. The questions they keep on coming, so
you need to get closer to the mic. It's hard to hear you.
I'm saying that I have some more questions, but if you want to close this session, that's fine. Whatever you.
No. Yeah, we have to keep a limit to it. Yes, I think it's closure, and I'll let you make the closing statement, Dr. Bhandari, and thank everybody.
Okay, so thank you, Sonia. Thank you, Professor Lee, Professor Wiener, Dr. Kamal, Professor Rui, Dr. Fobi, for joining us for this second episode of Virtual Bariatric University. Thanks for accepting our invitation. We might invite you for our next coming VBUs as well if you are free, and I love to have an interaction with you. And there are a lot of questions from the audience. We will personally inbox you those questions to whomsoever it's addressed to. Thank you, Rui, for a fantastic presentation, and goodbye, everybody. Thank you.
I have one message.
Bye-bye.
Go ahead.
Yeah, go ahead.
One message. Frankfurt meeting will happen. 300 people only in November 19 and 20. Live surgery is 2 days. Just limited 300 people are allowed to come to Germany, to Frankfurt, for Frankfurt meeting.
Thank you very much. Thank you very much.
Sure. We look forward. Thank you.
Thank you. Bye-bye.
Bye-bye. Good to have seen you, all of you.
Thank you. Thank you, Luigi.
Okay. Bye-bye, everybody.
Bye-bye.
Bye.
Bye-bye. Thank you, Matthias.